We would like to present the management of a patient with pelvic venous disease treated in Trinidad and Tobago. This is a possible first in the Caribbean. Pelvic venous disease or pelvic congestion syndrome, as it was previously called, is an underdiagnosed and therefore undertreated condition. We highlight this case to raise awareness of this condition, and the presentation is by no means a fully comprehensive overview. We present the case of a 65-year-old female who presents with pelvic and flank pain for many years, worsening progressively with time. She describes deep dyspareunia and pelvic pain a few minutes after intercourse. She has no significant past medical or gynecologic history. Examination revealed no significant abnormalities apart from mild varicosities below her knees when standing. A duplex scan of the abdomen revealed significant narrowing of the left renal vein between the aorta and the SMA. Color flow assessment confirms the findings. Here we see the CTA, which demonstrates stenosis of the left renal vein between the arterial nutcracker 14 seconds into the clip. Both dilated ovarian veins and dilated pelvic veins can be seen 30 seconds into the clip. The sagittal plane revealed a sagittal branching angle of approximately 25 degrees, normal being 35 degrees and above. A conventional venogram confirms the narrowed left renal vein, but more so facilitated the measurement of the renocaval pullback pressure gradient of 15 millimeters of mercury, the normal being less than 5 millimeters of mercury. Here we see contrast refluxing down the left ovarian vein. The dilated tortuous pelvic veins are then filled with contrast, which outflowed to the IVC via the right ovarian vein. The dilated tortuous pelvic veins are then filled with contrast, which outflowed to the IVC via the right ovarian vein. Over an Amplatz wire, a 14 mm by 6 cm venous wall stent was passed. The venous wall stent was deployed from the confluence of the left renal vein and the left ovarian vein to just beyond the IVC. Completion venography revealed free flow from the renal hilum into the IVC. There was little retrograde flow noted down the left ovarian vein. Pressure measurements now showed no significant renocaval pressure difference. The patient experienced immediate cessation of her original flank and pelvic pain, but described the onset of a vague, dull back pain which lasted for 1 week. She is currently asymptomatic. A venous duplex at 3 weeks post-procedure reveals a patent stent with flow, no reflux down the left ovarian vein, and shrunken pelvic veins. Some points for discussion include: is the correct decision made to intervene? Is the correct stent being used? Should the wire be parked in the renal hilum or left gonadal vein? Should pelvic and ovarian vein embolization be considered part of the primary procedure? What is the ideal post-operative follow-up with regards to anticoagulation and investigation? So remember, not all venous disease lies on the surface. The nutcracker syndrome, where the left renal vein is trapped between the aorta and the SMA, may not be as esoteric as we think. Thank you.